Steve, thanks for being with me today.
Oh, it's a pleasure.
So Jefferson is really using technology in new ways to reach out to the patient or consumer. Can you talk a little bit about what your global strategy is there?
Yeah, so we decided at Jefferson, we're a 190-year-old institution, number 17 hospital system in the country, but we decided that the real key is going to be how do we really connect with patients at a different level? I mean, think about this. Patients do everything on devices like this except for health. So we just decided we were going to redefine Jefferson as the place where tomorrow's healthcare happens today.
And what are some of the innovations you're leading, telehealth being one of them? Can you describe how you're approaching that?
Yeah, so we don't look at it as much as telehealth as we look at really creating what we call patient-provider stickiness. How do we have people starting from home think about Jefferson, whether it's wellness or a problem they're having or deciding what their next healthcare visit is? So telehealth becomes one very, very important piece to that.
Can you describe a little bit about what you're doing?
Sure. So what we've done is we've partnered with a company called American Well, who has really been one of the leaders in telehealth. And we're looking at all the things that don't make sense in the current hospital or healthcare environment. The two things we're starting out immediately, virtual rounds. Think about this. Your mom's in the hospital. Did the doctor make rounds? Yeah, I was half asleep. Okay, well, could the doctor call me? No, the doctor's busy in the ER or OR. Now, at Jefferson, you'll be able to, doctor will press a button, you on your iPhone, on your iPad, will be able to participate in those rounds.
So what's the goal of that? Is it to just get better family involvement in that? Is it better patient involvement?
Well, you think about, we always talk about the triple aims of cost, access, patient satisfaction. All three of them get involved. We want patients to feel that they and their family are involved in their care. So the ability to know that when your mom or dad is being discharged, you know what's going on is important. The second thing we're doing, which will be a little later this fall, is virtual discharges. I mean, think about readmissions, a place like Jefferson, which does tertiary and quaternary type services, and then goes back to a family physician in a rural area. Now that family physician will have all the discharge instructions archived, or could be part of the whole discharge team when we talk to the patient. I believe the number one problem in readmissions and continuity is communication, and telehealth is a great vehicle for communication.
So in something like the virtual rounds, what are the logistical challenges you have to overcome to do that? Make sure that the family members by the phone, for instance, things like that? Well,
the first thing you have to do is have a willing physician complement. And we've hired an individual named Dr. Judd Hollander, who came from University of Pennsylvania, and his whole team that has really started to go around to our hospitalists and other physicians, getting them excited about it. Then we'll have an advanced team that literally makes sure right before they go to the next room that everything is set up. And again, like any other technology, we'll do it as a pilot to begin with. But the fact is, the technology exists. It's just been getting the doctors and nurses' willingness to make that part of the rounding experience that really has to change.
So it seems like some of the things you're doing are a little bit ahead of where the rest of the field is. Is it your philosophy to sort of get out in front of where the field and technology even is at this point?
My hero was Steve Jobs, and I think one of the great things about Steve was he was able to think what's going to be obvious 10 years from now and do it today. It is absolutely clear to me that 5 years from now even, we won't be using this for trips and for travel and for shopping and everything else. One of my friends said, it's amazing that I can, the day after Thanksgiving, do all my holiday shopping in my pajamas watching Game of Thrones, but if I have a stomach ache from Thanksgiving, I got to wait on the phone and then wait 3 hours to see a doc. There's no chance that's going to happen.
You mentioned the physician component of this. How do you get them on board with more use of technology, more use of telehealth? What are your plans to really get them involved?
So the first thing is that we've made a big deal to our physicians about what we call the new math. If you're running an academic medical center today, it's NIH funding, ooh, that's going down. Clinical reimbursement, ooh, that's going down. Tuition, can't keep increasing tuition. So we've created a whole new organization around the new math, which includes innovation and philanthropy. So we actually have our CEO of our innovation pillar is at the same level of our provost and the CEO of our clinical pillar. So what starts to happen is physicians feel that they can actually be optimistic about the future because of these innovations. And the ones that didn't, I said, look, can you give me an optimistic future that just looks at NIH funding and hospital admissions? So we've been able to really turn that around. My one advice, though, for people that are thinking about going in this, you cannot overinvest in physician leadership, because the key is getting physicians thinking differently about a very different future.
And you're looking to create a national telehealth academy. Can you describe what that is and how it's going to operate?
Yeah, so one of the beautiful things about being entrepreneurial and academic is that we can do these really cutting edge things and really be the leader in telehealth and patient provider stickiness. But I also run one of the largest health sciences universities in the nation. And we're going to use that opportunity to do research on what works and what doesn't. So when people say, boy, I don't think telehealth works because I think people are going to get sicker, or I don't think it's going to cut costs, we're going to actually do studies that look at one group of patients that does things through telehealth, one group of patients that accesses the emergency department in a normal way. We need that kind of data to get rid of some of the myths either way. That telehealth is either the panacea or telehealth is going to be something that kills American medicine as we know it.
And I imagine having some of that data will also help with the reimbursement piece, which is one of those things that's always talked about as a roadblock to telehealth.
Look, one of the things that I think is a problem is that we've taken very much of a guild mentality. It's probably not going to help some of my fellow physicians, but the fact is that we have to look at non-physician providers, we have to look at things like telehealth to do a better job and get patients more engaged. And I think a lot of the reimbursement challenges, the parity challenges, the fighting around licensure has really not been based on real data. We're going to get the real data out there, and then frankly, if there's a reason to fight it because of political reasons, then at least that's what it is. But we believe the data will show that giving patients access to physicians, their physicians, through different communication tools can only be a good thing.
One of the challenges, obviously, that all providers are facing is that readmissions piece. So how do you view technology and telehealth in helping combat and improve the readmission component?
You know, I'm glad you asked that. I think it's a huge thing. I mean, think about this. We have a system where we have family physicians that never enter the hospital. Then we have hospitalists that never leave the hospital. And then we hope that somehow they'll coordinate. When we looked at readmissions, and we have one of the few schools of population health in the country at Jefferson, we recognized that a good part of readmission problems are for communication issues. So you think about it. At Jefferson, we do transplants, we do coronary things. We send it back to their primary care doc. That primary care doc is not used to handling the post-op sequela of some of these coronary pieces. They send that patient back to the ER if there's a problem. What we want is our hospitalists to be able to be available to these patients for 90 days, post-hospitalization, through telehealth and other means, so those patients know they can always get that person that took care of them. It might just be something simple like two-way electronic communication. It might be using an extensivist model where they actually see the patient in the patient-centered medical home. But in the pilots that we've done, we've been able to reduce readmissions by 20 or 30%. So if we want to reduce readmissions, communication is going to be key.
Great, Steve. I appreciate your time today.
Thank you. This has been a lot of fun.